Meeting. I've got the honour of the last talk, which is extraarticular releases. Most of the stuff I'm going to be talking on today is in regards to post-traumatic, which is what I tend to deal with. When I look at shoulder stiffness, the groups that I'm interested in, the post-fracture particularly, and these groups can be divided into the ones that have been fixed and the ones that haven't been fixed. You've also got the other groups there, which we all know about. So what's the natural history of a stiff shoulder? Well, it's difficult to determine, and that's the biggest problem when you're thinking about doing a release. We know that the function of the shoulder improves for up to 3 years and sometimes even longer after you've had a traumatic event. We know if you don't restore the anatomy, it doesn't matter what you do in terms of your soft tissue releases, as Graham said, you won't get a good outcome. And we also know that if a patient's diabetic, then that really adds a few worms in the can, so to speak. The other issue is, when do we go in? And the problem is, if you go in too early, particularly if you're dealing with a 4-part fracture, if you start doing big releases around that fracture, then you get a high risk of getting avascular necrosis. The other thing is it may be unnecessary. Now, the downside to leaving it too late, particularly if you've got a really stiff shoulder, is that you get a lot of cuff atrophy. And some of the ones I've done even 9 months out get fantastic passive range, but trying to restore that active elevation from getting the cuff to work is very, very difficult. The other thing we look at is what are the patterns of stiffness. Now, you can get that group which has just got that mild persisting stiffness, which is only about a 15-degree loss of range. And I think you can probably release those at any time. The real groups that I see, the Matson captured shoulder group, and they're the ones that lose their external rotation and abduction, and that may or may not be with forward elevation. It's usually severe. In the severe groups, it's mainly asymmetrical, so it still tends to be the external rotation. So it's the anterior structures of the shoulder that you really need to address. So what are my groups of stiffness? Well, I try to break it into 3 groups. So there's a primary, secondary, and the tertiary group. So primary stiffness to me is approach related. So if you do a deltopectoral approach, you lose external rotation. I've been trying lately to do most of my plating through limited incisions, through either a perk plate or a combined perk plate laterally with a small deltopectoral window to do the calcar work. I haven't done enough to say that it's a big difference, but this is one guy who was 7 weeks after his fixation of a 3-part fracture. That's his active elevation, his active external rotation. So I think the approach is critical, and certainly when you come to do the releases, it is absolutely critical, the difference between the 2 groups. Secondary stiffness, well, this is the big inflammatory response, and this is the big unknown after you have a traumatic event. You certainly see it on the bursal side. The bursal, as you know, if you go into a fracture at 3 weeks, can be up to ½ centimetre thick, and you're there with the nibblers clearing all that rubbish out. That then becomes the soup that gets everything to stick down. The deltoid just gets cold welded down to the pec minor, onto the coracoid, onto the subscap, onto everything else. The secondary response you see is therefore inside the joint, so you tend to get this adhesive looking capsule, and it's an anterior thickening. So the interval gets thick and the anterior part of the inferior glenohumeral ligament gets thick. Surprisingly, the posterior capsule can stay remarkably thin. It can still only be a couple of millimetres thick. The tertiary stiffness, and this is something that we need to think about, is a physio-related thing. So you get this asymmetrical pull. At the front, you're getting an unopposed pull of the pec major, which is pulling and it's contracted. And also you get the contraction of the lat dorsi, which also contributes to an internal rotation contraction and also loss of forward elevation. When patients don't use their shoulder, they get dramatic serratus weakness. Okay, so you get this condition where the whole scapula just rolls forward. Now, it's impossible to treat the front conditions until you do the releases, but the main thing before I operate is that the physios must rehab the serratus anterior. If that's not working after you do a release, you'll never get control to get the scapulothoracic rhythm and get the shoulder working properly. So when's the optimal time to release? Well, the benefits after 12 months, if it's a severe case in my hands, is questionable. So if you've had a stuck shoulder that's been stuck post-traumatic and it's less than 20 to 30% of normal movement, I think you're probably wasting your time trying to do a release after 12 months. 4 to 7 months for me seems to be the optimal time. As I said before, if you've got that group which has only got a little bit of limitation in their range and their cuffs working, I think you can leave it till after 12 months. So who do we work out to release? So my criteria for release is a severe loss of external rotation or if they're not progressing with physiotherapy. But the key is that they must have restoration of anatomy, and that's absolutely critical. Now you can see in this guy here, this was a push bike versus car. He said he saw his arm swing around 3 times as he came off his bike. His clavicle was in 4 parts, his head was split in 2, he had no calcar, and everything sort of down his shaft was highly comminuted. Now I fixed this, and I haven't fixed it that well. you can see that he's rotated into varus. Yet after the release, he maintains fantastic rotation, but he's not getting good active forward elevation because you've got that varus moment arm and you've got loss of the excursion of the supraspinatus to maintain it. The anaesthetic's critical. They must be intubated. This is the only time I really do arthroscopy in the lateral decubitus position because I find it easier to do the inferior work along the scapular neck and taking down the long-headed triceps. My anaesthetists do a pure sensory block, so they're down to 4 mils and 1% Narrapin, and it's critical to have a constant map. So somewhere around 7 is optimal if they'll tolerate it, which is easier to do with them on their side. As Graham said, sometimes it's impossible to get your camera into the joint, so a humeral osteoscopy is certainly always your first option. So my preferred way for getting around this problem is to come through the subacromial space. You must have your landmarks. This is difficult surgery, and it's probably the hardest arthroscopic surgery that I do. Your 3 main landmarks, your coracoid process is critical, your anterolateral corner of the acromion, and the entire length of the clavicle. So I dissect out, as you'll see, the entire clavicle so that I can see my landmarks to get from top to bottom. Akin to this is a little bit like hand mowing the MCG, is how difficult when you get in there. So this is one patient. You can see this patient's got absolutely no glenohumeral movement. All the movement is scapulothoracic. And this was 6 months after the internal fixation, which was done anatomically by one of my colleagues. Okay, so we start with the acromial exposure. So as you can see here, scope's in the posterolateral viewing corner, viewing portal, and some sort of ablator that comes in from the anterolateral corner. Now, if you just look here, this is what you're dealing with. Everything is cold welded down. It is really hard to work out where you are, and it's not just on that anterolateral corner. It starts from the clavicle, so from the clavicular head of the pec major all the way down to the deltoid insertion, all the way back up to the posterolateral corner of the acromion, and then everything else underneath that, then plus inside the joint. So we use a combination of using the shaver and the ablator, and you can see I've got my assistant pretty well trained. He can actually hold the scope backwards from the head of the table so that he's not getting in my way. And by using your shaver as both an outflow, a debrider and a retractor, you can really maintain a clear field of view. So the key to doing the medial superior release is that you need to get back into normal tissue, and what I've found is that once you get back to the level of the corticoclavicular ligaments, you tend not to get the adhesion. So when you come up into the level of the suprascapular nerve, there's no real adhesions back there, and because the cuff is all out to length, you don't need to really go any further. And here we come down, this is the region of the CC ligament. So again, probe the Nevisor portal and you can just quite easily work out where you are there. So that's where you need to stop your superior release. And that's the back of the conoid and the trapezoid ligaments there. I'll just sort of get through this. So the lateral gutter is the next point that we go to. Now, as you'll see here, intraarticular retractors are absolutely critical to doing these releases. I mean, when you do open surgery, you use both hands, and when you do you don't hold your eyeballs in one hand and try and use an instrument with the other. I mean, it's critical that you're basically doing this like an open release. This is a Langenbach retractor, which is brought through a low portal, and you can see, I know there's no axillary nerve there, so I dissect down as far as I can. The nerve's actually at the base of these adhesions here. So you're a fair way down the arm. I tend to take the plates out, and we do that arthroscopically. So we take all the screws out through the top, and I'll show you how we get them out through the bottom at the end of this. And then we come all the way down. This is the insertion of pec major, and that's the biceps heading under pec major. And you can see this patient is a separate, different patient than the one we're showing. This one's had a double plating due to a 4-part fracture. I'll just go through that through. So now we come to our anterior part of the release. So this is the hardest part, I think. You can see this is another case. The rotator middle has been closed by, this was done by a trauma surgeon in Sydney. And he's closed up the rotator interval, which is a really easy way for me to find where the entry point is to the joint, but not always do you have that advantage. So where we painstakingly go now is you follow the anterolateral border of the acromion around till you find the clavicle. Now I don't know when anything's going on to the right here. Okay, so this is a right shoulder we're doing, and anterior is off to the right hand side. So what I'm doing here is just trying to find where the clavicle is. Now it looks like fairly aggressive dissection, which you'll see in a minute. And what I end up doing is basically detaching the whole anterior deltoid off the clavicle, but because the deltotrapezial fascia is intact, it doesn't matter. Okay, so I've done this several times, and it just sits back down. The only difference is if they've had a previous approach superiorly. So if someone's done some AC work and taken down the deltoid, or there's been a clavicle osteotomy done, you can't do this. Okay, the whole thing will just end up in midair. But this is the medial. So this is past the S bend of the clavicle here. So where we're coming up now is up to the clavicular head of pec major, which is the next structure we see. So that's coming into pec major up here. Okay, so and now once I've found that, I can start to join up the dots. So okay, so I've found the most medial point on the clavicle, I've found the most distal point on the deltoid insertion, and then it's just a matter of sweeping everything else down as you go. So where you can get into trouble though is, sorry, I'll just show the rest of this one. Yeah, I think that's just going further along the clavicle there, which we don't really need to go. Where you can get into trouble though, this is a left shoulder now, a different case. This has had some AC work done. This is quite medial. They're the subclavian vessels. So that's there. So if you're not careful and you just sort of do that blind sweep straight down, you can end up going straight through the subclavian vein. And so that's the transverse part of the clavicle. This is the subclavian vessels, and this is a patient that I did a bit of a posterior cord neurolysis, plexus neurolysis, and a release around the coracoid and anteriorly because he had some chronic pain after an AC reconstruction, which I did. So this is going back to the other shoulder now, so we just do a little tour. So this is the whole clavicle dissected out. This is subclavius. This is pec minor. This is coming back to the coracoid. This is about an hour and a half into the operation, so they're big cases. This is pec major coming across the arm, going down. This is long head of biceps, and this is pec major inserting over the top of long head of biceps. And if you don't have your patient intubated and they've got an LMA, at this point they'd be dead. Okay, because there's so much swelling in the anterior chest, particularly when they're on their side. So my patients, I book them into HDU overnight when we do these big releases. So how do we get to the joint? Okay, well, the first thing we need to do is define the coracoid. The coracoid is the vein in the joint. The inferior border of the coracoid brings you straight back to the glenohumeral joint. It's a safe way to get in the joint. It doesn't matter if you cut the labrum there, and it leads you straight onto the where we are. So here we come, straight under the coracoid, bang, you're in the glenohumeral joint. Okay, but we haven't finished there yet. We're still going to do a 360-degree release of the subscap, and you can see everything's just stuck. And even though this patient's had a deltopectoral approach, the subcoracoid adhesions to the subscap. So you need to come right in through here and free all this up. And then you need to go either side of the subscap, as Graham showed before, coming down the inside of the subscap. That's fairly safe in there as long as you've got your blade pointing back up to the coracoid. And then starting the release, you're taking out the top of the IGHL, and then we come down the neck of the scapula and just free all that up both sides. So now that we've done the back side release of the subscap, we need to do the front side. And again, I apologise for the video on the next one. This is at my public hospital where the visibility is not great. So this is the left shoulder, that's the subscap. This is the conjoint tendon, that's the coracoid. And you can just see it's just these amazing adhesions that just develop through this bursal soup that just throws up the inflammatory response. So we dissect down to the musculocutaneous nerve down in here and free up the conjoint tendon all the way off the front of the subscap. And you do need to head medially because these patients have been internally rotated for so long. If you don't get in here and free up the back of the axillary nerve and the subscap nerves, it does just tether, and they just won't. They get pain with external rotation. So you can see as you come in here medially, it's just all soupy and yucky. And you can see these are the branches of the subscap, upper and lower subscap nerve. And we're starting to get now into relatively normal tissue. Okay, so that's probably as far as you need to go medially, and just for interest is showing the axillary nerve, and behind that's the radial nerve. So how do you get into the joint? Well, it's a front to back technique. So we just use a Wissinger rod, as you can see here, and that then gets me out through the posterior portal, which is just a simple inside-out technique, so I won't show that anymore. So this is the post-operative range, and we don't stop the release until they've got full range. So that's all right. No, that's all right. It must have been something I said. Bloody hell. All right. Yeah, so sorry. So the post-operative range, so we don't stop, the release isn't finished until they get full range, but they do get full range if you just follow all those steps. And my intra-articular release is quite aggressive, as I said, down the scapular neck. I come through 2 low posterior portals, and I take the long-headed triceps down, and I find that that's quite important as part of your release. I've done that in about 20 of the 80 releases that I've done, and it doesn't seem to cause any functional problem. They certainly don't get a cosmetic deformity from it. My post-operative regime is similar to Graham's. I put a subcoracoid catheter in, so I actually feed my epidural catheter down under the coracoid process and stick it into the plexus. And I find that if you run it in there, the pain relief is much better than what it is if you just stick it in the subacromial space. They get oral prednisone and gabapentin, and they're on a CPM for 3 days, and then they go to hydrotherapy once the wounds are healed. So just to give you an idea of where we are, so this is the same patient that you just saw. It's done through lateral to cube, so you can certainly get to these suicide portals fairly easily, even if they're on their side. And it's not showing up that well, but this is my lower 2 incisions for coming under the scapular neck. And it's quite safe. As long as you coplanar with the glenoid there, there's nothing really there that you can damage to get in there. And because you're following yourself through, you can see it's all done under direct vision to do the inferior release. What's not projecting that well here, this is the incision I used to get the plate out. So once I've taken all the screws out and I've finished the release, just make a small incision to take the bottom 3 screws out, and then you can just slide the plate down under the axillary nerve. So you just push it down distally, and then you can just pull it out through the skin. And it just means that you're not violating any of that superior deltoid there, which means they can get going a bit easier. So this is a scapular fracture. This is 10 days after his release. He had an internal rotation contraction. Sorry, his internal rotation was severely limited. So he was no internal rotation and abduction. He abducted about 70 degrees. You can see there after release, it's only 10 days afterwards. He's done quite well. This is the lady we saw with the double plating. Now, she got to me 9 months after her fracture and having a bit of trouble getting her cuff to fire. And I've been working hard with Rod Whiteley to work out patterns of trying to improve that. And I mean, she's actually done pretty well, but you can still see she's got weakness of her cuff, but she maintains quite good rotation. That's 3 months out. This is 2 years after a 4-part fracture and a hemiarthroplasty. So you can see reasonable forward elevation. I mean, that's active forward elevation. Passive, you can get it right back. But they maintain their external and their internal rotation. So this is a fantastic operation for restoring rotation, and quite reliably. The difficulty I have is working out the timing of when to do the releases and how to get the cuff to fire afterwards. And I find that that's a difficult thing. So I've been doing this now for 3 years since I've been in practice. Of the 80-odd releases I've done, 40 of them have been for post-traumatic. And I've had 1 transient axillary nerve palsy, which was the one we showed. I got a big bleeder there and buzzed it and ended up with a transient palsy. And also, she was mainly transient dislocated, because I think when I came in and did the joint release, I was a little bit too close to the glenoid margin. But fortunately, that settled after about 10 days or so. Thank you very much.
Okay, 2 very interesting talks for problems we've all encountered, both post-traumatic and idiopathic stiff shoulders. Obviously there is... Ed, you going to come and join us? You're going to sit in the corner there. Obviously we're dealing with very disparate types of pathology here, and I think that when we ask questions, maybe we should be quite clear whether we're talking about post-traumatic stiffness or we're talking about the idiopathic frozen shoulder. Greg, would you like to start, Bob?
What you've shown us really is soft tissue endoscopy, which is a different principle to what nearly all of us in this room have been practicing. My question really is, you've got, you're doing it underwater. The other concept is doing it as a more of a, putting in dilators and things. There's Reimer Hoffman, who sells or promotes all the Storts equipment. My question really is about the use of doing those techniques with retractors versus using yours as a endoscopic underwater technique.
Yeah, I didn't know about that, to be honest. I mean, I do use retractors, and I use Langenbach retractors as my main form of retraction, and they actually, I didn't sort of talk about the whole video, but they come in everywhere, and so I've got opening up that space, but because I use a lot of diathermy and it's a long operation, I like to have it cooled with fluid. But yeah, I take your point.
Yep, up top.
Could you just comment on whether a chromioplasty should ever be done or never be done, and what the influence of it is if you do it?
Is that to me or to
Do you mean in
actually to
context of a release, or are you talking about as in context of cuff repair?
In release.
In release, okay.
Yeah.
Sorry.
You have to. I mean, I rarely do an acromioplasty as part of my routine cuff repairs, but in this setting you have to. And the reason being is the physios won't be able to get them going. Even after you do the releases, you lower the humeral head, but due to the disordered mechanics of the shoulder, the first reaction they tend to do is to bring the humeral head up. And I find that that it's just the first 6 weeks. If you don't do the acromioplasty, then they're behind the ones that if you are. But I think for routine cuff management, it makes no difference.
Slightly different. I think if people have a pathological profile to their acromion, which I'd consider a type 3, whether it's due to a spur or developmental, then I would do a acromioplasty with that. It does induce another area of discomfort, and it does induce another raw area that can exude those factors which we don't understand. So I will do it when I think it is contributing to a secondary source of pain, but if it's a relatively normal profile, I'll leave it alone.
John Moore.
Graham, your releases for frozen shoulders, your rehab, you didn't mention, or you don't use any post-operative intraarticular steroids or oral steroids. Do you see a need for that? You're not actually attacking the disease with releases. You're releasing the disease process inactive, irritated with trauma.
Understand, and that's why I prefer to do this as a later procedure on that sort of peak of the curve where you know if you rub Vegemite on their shoulder they're going to get better, but with an arthroscopy they'll get better faster. So if you do it early, then I think you've got to whack them with steroids, both oral and at the time of surgery. But I don't routinely do the injectable steroids.
Yep. Oh, sorry.
Letter for Graham. I noticed you left the biceps alone. How often do you take that out in a capsular release?
Okay. I can't give you a number. If it's adherent to the cuff and I can release it easily, then I'll release it and leave it. If it's adherent to the cuff, densely adherent, I'll often do it at tenotomy at the exit.
John.
One more question. You've got the situation with the frozen shoulder and a pathological cuff tear. How do you handle that?
Okay, I asked this question of Bob Naviser in 1996, seven actually. Actually at the one of the shoulder and elbow meetings in the States. Charlie Rockwood didn't understand my English. He said, "I know you're speaking English, but I don't understand a word you said." And that's an aside, obviously. So the patient comes in and they've got a stiff shoulder associated with a either acute or chronic cuff tear, which perhaps has been symptomatic before they got capsulitic. I will advise them on the... I can either run their rehabs concurrently, okay, in which they will be out of action intermittently with shoulder problems for up to 2 years, or if they wish a more aggressive approach, I can do a release and do a repair at the same time, accepting that the 6-month rehab that I'd normally give my patients may be extended. The worst case scenario, I may have to do a release at the end of that time. So possibility of 2 operations, but I can commute the sentence, so to speak, to a much shorter time.
So you do a release and the cuff tear, and post-operative is your rehab change for that as compared to a cuff tear repair?
I try and, yes it does. I'd use the CPM post-op, and all my patients go into hydrotherapy around 2 weeks anyway, so I'd continue that. And I do try to push them overhead with, it obviously depends on the cuff tear itself, but I try to push them overhead with their rehab if that's comfortable on the table.
Yeah, fairly similar for me. I just accept that it doesn't matter what I do, they're going to get stiff again. I don't tend to do the release at the time of the cuff tear. I do the cuff repair. I don't take them very quickly. I just work on mainly scapular control. At 12 weeks, they get an arthrogram, and in the arthrogram they get corticosteroids. If there's no leak, then at 4 months I'll do a release, if they warrant it, obviously. But
One of the problems I've had, Ed, is you've got a fracture, you've fixed it, or whatever you've done in a traumatic situation, they come back to you at sort of 2 months and they're fairly stiff, and they come back to you at 3 months and they're getting a little bit better. They're not going great guns, and at 6 months they come back and they're still improving. When do you say enough's enough, you're not fast enough improving? Because what often happens with these people is they won't plateau for at least a year or more, and each visit you see them, there's just that little bit of an improvement, and you're holding out that it's going to have some sort of road to Damascus revelation and improvement. When do you actually say enough is enough, let's go and operate?
yeah, I find that really difficult. I think I'll try to get to that in my talk. I sort of break them into groups. There's the group that you know is never going to get better, and they're the group that just have no external rotation. They haven't had external rotation since day one, and if they present at 12 weeks with 0 or less than 10 degrees of passive external rotation in the plane of the trunk, then I know I'm heading for release, and I'd probably rather do that sooner than later so that they don't lose too much of their cuff function. The other group I look at is the group that's failing to progress with physiotherapy. So they're the ones I'll talk to their therapist, and if over a 6-week period they come in, they stretch them out, they get another 10 degrees, but then when they come back, they're back where they were, and that goes on for 6 weeks, and that's the group that I'll also release. So I think it's a difficult thing, but for me it's a time. I think if you don't get to them inside 9 months and they're stiff, then after that you've really got an uphill battle with rehab to get them going. So.
Well, what you demonstrated was a really massive release. Is there a hierarchy of structures that you look at, extracapsular, that you work on, that you test each time to see whether you have to go to the next step, or is that as enough? What's your hierarchy?
The ones I tend... Well, the difficult ones, so the 4-parters, that's the release. The other group that we look at, so starting anteriorly, so the anterior is coracohumeral ligament, rotator interval goes every time, the biceps will go usually as well. Then we do the anterior release of the supraspinatus off the coracoid base, and then we assess external rotation. Okay, so that's probably the main step. Posterior bursa always seems to be a culprit, and I think it's one of the persisting causes of pain, so I think it's important to get the posterior bursa out. Now that's often enough for a lot of fractures.
Posterior subscap, we're still anterior, or are we talking about
posterior? Sorry, posterior bursa, so posterior superior cuff. Sorry, I apologise. Then move to the posterior superior cuff and take out the bursa. Now if they have full range with no springing, and it's the springing is the key, so they have to come up and have no firm resistance coming back down, then you can stop the release. But usually what I find, even doing that, they still spring in external rotation. So you're often taking the top half of the inferior glenohumeral ligament anteriorly as well. So just in its mid-fibres going down to the 530 position to release that as well. But then after that, then it's dealer's choice. But those big ones, I know I'm in for a 3-hour operation, and that's just the meal deal for those.
Any other questions?